Hello, and welcome to the Duke Endocrinology Conference. I'm Diana McNeil, Professor of Medicine at Duke University Medical Center. Today's program is titled, What's New in Diabetes Mellitus Treatment? And our distinguished guest is Lillian Lean, Assistant Professor of Medicine at the Duke University School of Medicine in Durham, North Carolina. Lillian, thanks so much for joining us.
Well, thank you for having me.
So Lillian, what's new in the management of diabetes mellitus?
Well, there's actually a lot, which is one reason why I think it's very exciting, because our field is moving at lightning pace. So I thought a good thing to do would be to go ahead and get started with just a brief update of how we'll go through this. So I thought step one, just an introduction on glycemic control. Why do we care about this at all? Another issue then is to talk about diagnosis of diabetes, which has actually not changed for a long time, but as you and I both know, in the recent couple of years, there's been a lot of discussion about how to do that, and we'll get to that. Also, we'll talk about insulins and particularly some of the new agents that are appearing on the market that are non-insulin anti-diabetic agents.
I'm sure we don't have to tell our audience that this disease is in epidemic proportions right now.
No, we don't. And I was actually shocked to see this morning that the CDC just released a report that said that in 2008 there were 57 million people with prediabetes. 2010 it's 79
Oh my dear, oh my dear. So I think it's going to be important for us to recognize what prediabetes is. Actually, I think they may even have changed the terminology for that a little bit. And then also what we can do about it. We've got to stem the tide, it seems.
Right. So there's a lot of recognition and how to address that. That is key.
Good.
So in terms of why this is important, in other words, why do we care about the 79 million who may be at risk and the 20-odd million that do have diabetes? The reason is because we know that glycemic control has been shown to promote healing. So actually, after surgery, that's a particularly important point to prevent infection. And also, there have been data throughout the years that say that improvements in hyperglycemia have reduced morbidity and mortality. And I think that's an important point because, as you and I both know, there's been a lot of discussion lately about glycemic control and targets. And I think that's a good discussion, but there's never been an argument that we have to prevent hyperglycemia.
And so in this slide, you're talking about reducing morbidity and mortality from all diseases or a specific subset of diseases?
Actually, for many diseases, and particularly even just literally mortality. That's an issue that can happen. Even ICU mortality has been shown to improve potentially with glycemic control.
So it's not just cardiac disease.
Right.
It can be anything.
Actually, yes. There's a lot of studies that have recently opened this up and said that we've been looking at the vascular aspects of diabetes, but the fact is the implications on all sorts of things, including cancer, are actually quite huge.
Okay. And then a lot of our patients will always tell us that one of the things that sometimes makes them think that something's not right with their blood sugars is that they have poor wound healing. So this has actually been clearly substantiated in biochemistry and physiology. Right?
Exactly. And as you say, the physiology behind it probably explains why that poor wound healing in someone postoperatively can actually lead to a higher risk of sternal wound infection after bypass, et cetera. Those are the things that we're trying so hard to prevent.
Okay. Very good.
So let's move on to diagnosis very briefly. So what I'd like to do is run through the stuff that you and I have heard for many years, which is the original method of discussing how to identify someone with diabetes or how to make that diagnosis, and then add a little new kink into it that we'll talk about that has some controversy that goes along with it. So in the past, many of us have been really, basically, our patients will ask us the question, what is a normal blood glucose?
Right.
And that's probably one of the most important things to address, because I'm sure, as you and I both know, the answers are all sorts of things. So
true. And they often don't use the word glucose either. They say, what's a normal sugar?
That's right.
Sugar.
So yeah, exactly. What should my sugar be, right? And you get all sorts of answers.
Yeah.
So really the answer is fasting. If we talk about first thing in the morning, it should be under 100. That's been the key for at least the American Diabetes Association for many years.
In the outpatient setting?
Correct.
Not
in the outpatient
necessarily in the inpatient setting?
The targets in the inpatient settings are a little bit looser. We would still... It really depends on what perspective you're coming from, but it is certainly true that the pre-meal target in the inpatient setting has been loosened somewhat. I'd say around 140 is the target that they've been using.
Lillian, I think there's some concern among patients for sure, maybe for their providers, about making the diagnosis of diabetes for the first time in an inpatient setting. Is there still that concern?
Yes and no. Certainly, I would say that if you had a diagnosis that was just based on a single value, that's an appropriate concern.
Okay.
That's not necessarily the time that we should be doing that. Depends on what else is happening, what other medications are on. However, if you have clear evidence, repeated values that are persistently elevated, absolutely the hospital is actually the best time to make that diagnosis, because otherwise they would not otherwise know that this is a problem.
Right.
So it really depends on the accuracy and the repetitiveness of the measurements, so that you can utilize that and be confident about that.
Some of our patients, as you are very well aware, are concerned about being labeled as a patient with diabetes,
right,
because that changes their ability sometimes to get insurance coverage and life insurance and a whole bunch of other things. And so I think there is some concern about the accuracy of these criteria that you're describing right now.
So I think the important thing to say is, first of all, again, these are technical criteria which, as you say, are usually implied to be in a clinic type setting. But at the same time, I think what's important is if there is persistent elevation. For example, let's just say someone who comes in for an orthopedic surgery and has 250s repeatedly on their blood glucose, I think it's fair to say that we really need to discuss this issue. And, you know, I think the idea of whether you label someone or not is much less important than simply saying that we've identified an issue and they can follow that up in the outpatient setting.
That's an excellent point. That's an excellent point.
So as you point out, if we are strictly talking about the ADI criteria primarily intended for the clinic, then a normal glucose is under 100. This term prediabetes is probably better in this setting known as impaired fasting glucose. So in other words, when you're having a problem with your fasting sugar, and that is defined as the criteria between 100 and 125 milligrams per deciliter, then actual overt diabetes by fasting criteria has been defined for quite some time now at 126 milligrams per deciliter.
So Lillian, you know this is an area of some controversy. Whenever we talk about any pre-diseases, there's some interest in whether or not this will be important to diagnose, and also, does it matter? Right. So why does it matter that we diagnose someone with prediabetes?
And actually, you raise a point that I think a lot of patients are going to raise, which is, why are you trying to tell me I'm pre-something when I don't actually have it? Right. Well, because, number one, we just mentioned a statistic that, again, I happened to see in the news this morning, 79 million from the CDC that have prediabetes. So, A, it's prevalent. Right. B, what can we do about it? This is the population that is probably should be our main target for behavioral modification and other things, because these are the people who we can prevent from having type 2 diabetes. And the CDC report this morning also pointed out that within 10 years there was a high probability of the people with prediabetes going on to develop type 2 without those modifications.
So the impact is both at the level of the patient and also in our bigger healthcare system, because diabetes is an expensive disease to manage.
And actually, I hadn't brought that point up, but you're absolutely right. Some of the CDC's implications are, I was thinking about 79 million, that's a quarter of the population. Wow. So if you think about the implications of that potentially, if even a small group of them, proceed to type 2 diabetes, if we're lucky and we do prevention, even the group that proceeds on will then potentially contribute to the importance of diabetes in the healthcare expenditures in terms of inpatient stays, complications, et cetera.
So the one question, and we get asked this all the time by the patients, is, Dr. Lynn, I'm going to treat my prediabetes. Will that prevent me from getting diabetes in the future? What's the answer to that question? Can I make it go away?
I would never be honest with someone by telling them it can completely go away. I would always encourage someone by saying that we can move you in the right direction. Okay. So even someone with type 2 diabetes who has done a very good job and may be able to take themselves back out of the, quote, diagnostic criteria, we never use the word cure. Right. But we also say it's not an issue of cure, it's an issue of your health. If you are more healthy and less at risk for complications, I don't care if we call it a cure or magic or what, it's the fact that you are better off and you will live a longer and more quality life. Right. That's the key.
Right. That's an excellent way to describe it to patients.
And okay, so that was the fasting criteria. Let's move on to something that, as you and I both know, Diana, it's not really done that often, but we often sometimes think it should be. And so there are individuals who may not be diagnosed by the fasting criteria. So the technical oral glucose tolerance test, the glucose challenge, would be to go ahead and do a 75-gram glucose load and then measure the glucose 2 hours post-load.
Right.
And the criteria for the cutoffs here, and this goes a little bit into the inpatient criteria,
Right.
is 140 would be considered, under 140 would be considered normal. Between 140 and 200 basically is pre-diabetes, or really much better stated as impaired glucose tolerance. And above 200 would then be diagnostic for diabetes. So again, to emphasize, a glucose over 200 post-load is indicative of diabetes.
So you started out by saying that we don't order this test very often.
Right.
Can you give our audience a couple situations clinically where this is a test that we would do?
I think that's actually a good point. I think if you have somebody who's coming in who's complaining of symptoms, or perhaps in some other circumstance, maybe as often as the case now, their spouse or someone has a meter and they happen to have checked after they've eaten and they've noticed elevations, but yet their AM, for example, on their physical, their fasting glucose has been fine. That might be an ideal person to say, well, if we really want to look and see why you don't feel well and why you might be having these numbers but your AM labs are okay, a glucose tolerance test would be one opportunity to do that.
A couple other situations that come to mind for me would be we do them all the time in our pregnant women. And then we also do it in our women with polycystic ovarian syndrome sometimes.
That's very true.
You know,
That's actually a huge point. You're right, Diana. That polycystic ovarian syndrome is so inherently both a metabolic and a fertility issue that we should be doing that.
And you reminded me of a case that I saw of a patient referred to me from neurology. Exactly as you described it, had horrible painful neuropathy, horrible neuropathy. Their fasting glucose was normal. Their hemoglobin A1C was in the upper limits of normal. Their glucose tolerance test was distinctly abnormal. And so I think, you know, when the symptoms don't fit the labs, this is a good backup plan.
A tool. Yeah,
a tool.
I agree. I think it's something that even the American Diabetes Association does not expect to be used as a screening thing widespread, but it can be used and very useful in those cases. Finally, the last point on the this particular slide is, again, one of the original criteria for the diagnosis of diabetes per the American Diabetes Association, and that is your patient who comes in, again, like we said, perhaps for orthopedic surgery or some other non-endocrine related issue, and they end up finding a repeated blood glucose of greater than 200. Again, in this case, the ADA specifically says it's a provisional diagnosis, and that is because, like we said, we want you to confirm the accuracy of the measurement, but also symptoms. Talk with that patient and find out if there are symptoms that are going along with it, and if so, then that's a very good likelihood that this is newly diagnosed diabetes in the hospital, which unfortunately is also becoming epidemic as well.
But the term you would use on a discharge summary or something like that would be provisional diagnosis of diabetes?
I think that would be very fair.
Okay.
Yeah, I think that probably, especially given the concerns about the implications legally and medical legally and otherwise, I do think that it would be fair that the patient could be told this is provisional, needs to be looked into, but that this is a circumstance that is not definitive per se.
And these are, again, relatively new, since we're talking about new aspects of diabetes management, new criteria that our listeners need to pay attention to, but because the older criteria were much higher numbers, and I think missed a lot of patients.
Right.
We're trying to garner some of the quarter of our population in earlier so we can...
Exactly. I mean, that's a really good point, because even the fasting criteria of diabetes at 126, as you probably remember, within, I think, the last 10 years, was actually higher.
Right.
So there's been discussions about that. There's always debates because it obviously changes the percentage of the population. But the idea is, again, not statistics as much as identifying individuals that we can make changes in and prevent the consequence.
Okay.
So moving on to, as you point out, what else are we talking about now? Well, for many years...
This slide, I love the blue balls coming in here. So.
Well, we have, for many years, have had a discussion about how to identify what's happening over a period of time and not just a snapshot. So we all know that a blood glucose measurement is a snapshot. So what if we want to know what's really been happening for the past couple of months, 2 or 3 months? Well, the hemoglobin A1C value is something that I think most of our viewers would be very familiar with, and with good reason, because it's a great way for us to find out the metabolic sort of integrated period of time over the life of a red blood cell, which happens to be about 2 to 3 months.
Right.
So one thing that I think is exciting about that is we also have validated methods of estimating what the A1C means in terms of the implied glucose value. Some of this data actually comes from the DCCT and some of the older trials.
DCCT?
diabetes control and complications trial, which is one of the first ones in type 1 diabetes that demonstrated that by controlling glucose, you actually could reduce complications, which again is going back to why are we talking about all of this, right?
Right.
So, and that in fact, and thank you for the prompt there, because that actually reminds me the line that is on the slide here is also from our large trials, which have demonstrated that if we're able to keep an A1C below 7%, we are able to be better at preventing complications, particularly microvascular complications such as retinopathy, neuropathy, as you just mentioned, et cetera.
Before you leave the slide, can you help us remember when the hemoglobin A1C may not be very accurate? Because we forget this sometimes.
Yes, and I was actually thinking that as we were talking earlier about how useful it can be, is that there are cautions that are actually quite important, and the ADA has actually emphasized this as well, is that anytime you have increased red blood cell turnover, so some type of hemolysis or any other process that interferes with the red blood cell, or perhaps sickle cell anemia, et cetera, these are times when the life of the red blood cell is not going to be normal, and therefore it's not going to capture a period of time that we think that it's telling us.
And the other time, which is one that gets us confused sometimes in the hospital, is if you've had a lot of blood transfusions.
Very important. You're right. Actually, I thank you for that, Diana, because the truth is that probably is even more important.
Right.
There have been a lot of cases where I'll be rounding with the residents and fellows and saying, which patient's blood are we actually measuring? And you would hope that it would be the person that it was drawn from, and I'm not implying that it's not. But the reality is if they've had a large-scale transfusion after a vascular surgery, that's not going to be an accurate reflection either.
And the other point, and you and I both see this all the time in the clinic, is remember it's an average. So if you have somebody who's really hyperglycemic and someone who's having
it could actually look pretty good
and
that's
be
not misleading.
Good, and that's not good diabetes.
And you raise a whole other point, which we can't get into right now, which is the question of glycemic variability. In other words, we would rather not be flying up and down, even if the average looks good. We'd rather be steady. So with all this discussion about the utility of hemoglobin A1C, why had it not been used before, right? And many our friends have been asking us this for years. Why can't we use hemoglobin A1C? And as we'll get to, it's still controversial. But the reality is that for the first time, the American Diabetes Association has actually put it in their standards of medical care, which is a big change. The reason for that is they recognize how widely used the A1C is, and they also believe that now in 2011, the standardization of the assay for A1C is actually pretty good throughout the United States. There's a caveat in there to say that in other countries this needs to be carefully considered. So even then they're having to use a caveat. Another big question was, if we do believe the assay is fairly reproducible, from state to state, for example, then what's our cutoff, right? What should we say? We talk about 126 for fasting, et cetera. Well, this has been a major discussion as well, but the current ADA criteria is 6.5%. There's debate about
for the diagnosis of diabetes.
Correct.
So lower than that, that's prediabetes?
Or some form of impaired glucose tolerance or impaired fasting, yes.
Lillian, a lot of our listeners may have point-of-care hemoglobin A1C machines in their office. Can those values be used also, or does it have to be drawn from serum?
Ideally, it should be drawn from serum because, again, the assay is really important. So the
point of care is okay for monitoring, but maybe not for diagnosis.
I agree. I think point of care would be useful for someone with known diabetes that's fit all the diagnostic criteria, and then you're just seeing how they're doing. But given the fact that this is already controversial enough with a standardized assay, I don't think point of care would be utilized for technical diagnosis.
Yes. Would you suggest to our listeners, based on the data that we have right now in prediabetes, that if they get an abnormal hemoglobin A1C, that perhaps they should check some other lab, like a fasting glucose in addition, or check it again? I mean, do you ever make it the diagnosis based only on one hemoglobin A1C?
Right. I would definitely want to actually, when you talk about fasting versus post, frankly, I would like to have both, and the easiest way to do that is simply a glucometer. And so, again, that's a way of maybe helping the patient recognize that we're moving into a discussion of metabolic issues, but not necessarily overwhelming them and saying, we're going to teach you all about diabetes. Let's just get data. Let's get blood glucoses. Let's see what those fasting and postprandial values are. And another point that you raised earlier in terms of the issue of, who do we tell what this is happening to and how does this have an effect on the population. The 6.5 is also somewhat debated because of the fact that some believe that that's only going to capture a portion of the population. You can have an A1C less than 6.5, but actually have technically impaired fasting glucose, which is why, again, your point about measuring the blood glucose is key, testing at some time, because the reality is the accuracy of A1C is the statistics for it are actually less than ideal in some cases.
I think what our listeners will hear, though, is that they now have another relatively easily test in their armamentarium for helping to make patients recognize that they're going to need to make some lifestyle changes.
Right.
And that's important. And the original statistic you told us about this morning.
And that's a really good point because I think that's what the ADA wanted, right? They wanted people to have something that's easy to use, that's there. But as you and I were discussing earlier about a recent 2010 article, the reality is the sensitivity of the A1C is actually only 27% when compared to the utilization of fasting glucoses as a gold standard. So we miss people if we just use A1C, but it's a good starting point.
That's right. Excellent. And I think ultimately it helps our patients start to think that they want to make a change in their lifestyle so they don't need to go on what I call vitamin I, which is insulin. Tell us about insulin.
Okay. So that is a key, in terms of the question of what's new, that is a key area. So a long time ago, life was actually fairly straightforward, and we had short-acting regular insulin, if I can get the pointer to work with me.
Wasn't that long time ago either. So you know.
A long time ago in the world of development, yes. But actually, not that long ago in real time, we didn't have much.
That's right.
So regular insulin was very commonly used, still is in certain circumstances. And that was usually the short-acting mealtime insulin that was considered to be the standard.
Affectionately known by patients as clear insulin.
Very true. That's what we used to teach, and it used to be an effective way of distinguishing short-acting and long-acting insulins. That's changed. So regular insulin is literally clear if you look at the bottle. Then we have our cloudy insulin, the NPH insulin, which we now call intermediate acting. But to be fair, for many years it's been used as a basal insulin, given twice daily, but that less used as a background insulin that was then a good basis for what to do regardless of meals. The issue is that NPH insulin has a peak and does not necessarily last all day. So there was a lot of technology that went into saying, how can we be more like the pancreas? How can we have something that is produced all the time and doesn't peak, is just a steady background? And also, how can we have quick spikes that would just address the meals?
So we're trying to pretend that we are releasing insulin as we would have if we didn't have diabetes.
Exactly.
Or if we were on a pump, perhaps.
Right.
Insulin pump.
So I think that's a good way to look at it. Or as we all hope for someday, perhaps the artificial pancreas is kind of the goal, but the closest we've gotten to it now is the pump. And how do we do rapid bolus releases and have a nice basal that truly lasts a long time? So the new basal insulins that have come into play and are now actually used quite extensively are glargine, also often known as Lantus insulin, and Detamir, known as Levemir. And these are very long-acting, potentially, not always, but potentially 12 to 24 hours. The ultra-short-acting also helps with this. We talked about the mealtime spikes that would be rapid-acting and also disappear quickly, and that's what Lispro, also known as Humalog, Aspart, known as Novolog, and glulisine, known as Epidra insulin. Those are ultra-rapid-acting mealtime insulins. And I think the next slide will help us understand this a little better, because the ultra-rapid acting truly it hit immediately.
It's food insulin.
It's food. And as you point out with that comment, we tell our patients, you have got to eat with this insulin, because it's going to go in 5 minutes potentially, and it's going to feel the effects immediately. And the duration of action is fairly limited for this group of insulins, about 4 to 6 hours. By comparison, our original mealtime insulin is still fairly rapid acting in the sense that it goes into action within half an hour approximately, but the peak is actually 2 to 4 hours later, and it can last as long as 6 or even longer hours. So we can't think of it as something that goes away quite as quickly.
So Lillian, in the physiology of trying to be the pancreas, it would make logical sense to me that you would want a basal and a bolus insulin. So why would anyone use regular and NPH anymore? Why would they do that?
Right. So,
I'm sure many of our listeners and perhaps many of their patients are on regular NPH. Is that okay?
That's certainly okay. I think there's two ways to look at this. If you talk to the individuals who would like to, move the field forward In other words, what's state of the art? There are a lot who say, just as you did, that to be the pancreas, the basal bolus concept with a true basal such as Lantus or Levemir and a bolus such as the ultra-rapid acting insulins would actually be first choice in many cases. In fact, there are some hospitals in the U.S. where Regulin aren't used.
That's
So that is in fact true. However, we, in our experience here at Duke, have not been able to move to a model where we can eliminate regular and NPH insulin, and I really don't, believe that that would be appropriate for a while because of financial issues, if nothing else. Certainly availability, accessibility, insurance, cost.
Okay.
Obviously, the newer insulins have come out more recently, and the cost differential is significant. And for many of our population, we talk about the statistics, how many people have diabetes or even pre-diabetes. To access these people, we need to have insulin in some form. And regular and NPH are accessible anywhere and for a minimal amount of money. And this is the population that we need to reach, is people who may not want to and may not be able to make huge expenditures on their health, and yet we can still do something to help them. So RNN is absolutely appropriate in certain cases. It's just gotten more complicated because sometimes that becomes a discussion. Which one should we use?
And since we're talking about new activities in diabetes, these multitude of insulins can be amazingly confusing, not only to patients but to our healthcare providers.
Right.
So I think, I know you and I both have used regular insulin in certain situations in the hospital, particularly if someone's on steroids, mostly because it
has a longer duration.
Absolutely. I think what I always tell the residents is you need to know the names of the insulins and their time course, and always double check what you write so that you make sure that you haven't confused the kinds of insulins for the patients.
And so in terms of what's new, I think the one thing that's new that's not specifically stated on the slides is confusion.
It's confusing.
The risk for confusion is new because in the past there wasn't that much to get confused about. Now we get calls from patients all the time. I'm not sure whether my clear insulin is really what it is, because I forgot to mention earlier that Lantus and Levemir are clear. So suddenly our short-acting and our long-acting insulin is clear, and NPH is still cloudy. So the techniques that we used in the past to prevent confusion are not as applicable now.
And I think it behooves us as healthcare providers to know the time course. I had a patient call last week who's on an insulin pump, Lillian, and as you know, we tend to put the very ultra fast-acting insulin in the pump, and the person grabbed a vial of insulin that was new in the refrigerator and put Lantus in the pump, and then found out about 2 hours later that their blood sugars were in the 400s, and we had to quickly figure out what
was wrong.
But you have to know the kinds of insulins,
and recognizing that again, that's a short-acting versus a 24-hour. And so briefly, we can look at this visually. What you were talking about just now is the ultra-rapid acting insulins. They peak right away and go away fairly soon. Regular actually peaks fairly soon, but has that tail, which is sometimes useful, as you said, in steroid patients potentially. And pH is longer acting, but it does have a peak, which can be problematic at times. The idea was for the newer insulins, Levemir and Lantus, or Detamir and Glargine, that is, generic names, they are much longer acting and tend to be less likely to have a peak, but I would also caution that there are exceptions to that. Dosage also has an effect on duration of action.
Does it matter which ultra-long or ultra-short insulin you use? Is there enough difference between, for example, the Detamir and the Glargine, or between the Apidra and the Aspart and the Lispro?
Certainly, if you talk to individuals who are involved in the development of these insulins, that you will get lots of answers about that, appropriately so. I would say from a practical standpoint, the majority of practitioners, including myself and you and others that we know, are not going to distinguish significantly between them.
All right.
Okay, so insulins are complicated. What's new in non-insulin medications, right?
There's been a lot of change here.
This is even bigger. And so this is actually a topic which I think is extremely exciting, because it really shows what we're able to do for our patients now that in the past was not even, we didn't even know that these were techniques that could be done.
And you said this at the beginning, but it's worth reminding our audience that the majority of patients are going to take care of with diabetes have type 2 diabetes, which is where most of these medications work.
And that's actually a very good point. In the case of insulin, of course, that's something that can be used in any type of diabetes. But in the majority of the non-insulin medications, almost all, with the exception of perhaps one, they should be used in type 2 because of the way they work. It will not be functional in a type 1 patient.
Okay, you talked about confusion. There it is.
And as you and I were talking earlier, when you look at the confusion, there's also the recognition that some of these have recently come on the market, some of them have come off the market. Right. So that makes it even more exciting. If you look back in the early 90s, which, as you say, is not that long ago, we didn't have much. We had insulin and we had sulfonylureas, and then in around 1995, metformin came along, and that was still pretty exciting. We had sulfonylureas and metformin, those two being oral, and of course insulin being injected. Then, within the last 10 years, or 15 at this point, the explosion has been amazing. So then we had our the glitazones, which came along. Initially, Resolin was the first glitazone that came out. That one was removed off the market because of liver complications. I think it's worth mentioning because its cousins, pioglitazone and rosiglitazone, Actos and Avandia, we really should probably monitor liver tests on those individuals as well. I don't think that's discussed as much. Certainly, they haven't had the reported level of injury that Resolin did that got it pulled off the market, but it's an issue we should be watching. And then other medications have come along, including the newer types of insulins and other types of oral agents. So that's how we've had this explosion of different options. Now, in terms of the way we look at how they work, it really targets all the different metabolic processes behind the pathophysiology of type 2 diabetes. So the metformin and the biguanides, which is the name of that class, basically work by improving hepatic glucose function. So in other words, you reduce hepatic glucose insulin resistance. Yeah. So you improve the insulin resistance at the level of the liver. In terms of other things, our sulfonylureas are our old friends because we know, it's easy to think of it, they do pancreatic insulin secretion. And that's a very easy concept to tell our patients as well, is we're just trying to get your body to produce more insulin.
Patients have called it, for many years, oral insulin. And I keep saying that's not exactly oral insulin, but, hold the thought. I mean, it's close in concept.
You take the pill and your pancreas produces insulin. In that sense, that's not inaccurate. I will also say that some of our colleagues are not fans of this because if you think about it, are we really wanting to be stressing the pancreas long term, to be forcing a pancreas that's already under a lot of metabolic stress to be working harder? That's a huge debate. Nonetheless, sulfonylureas are used quite often. Our other agents, our rosiglitazone and pioglitazone, actually work at the level of peripheral insulin resistance. So that's what they target. Other agents include acarbose, not used as often, but it actually affects carbohydrate absorption, has some A1C lowering effect, not very commonly seen, but it is an agent that's out there.
For our listeners, this diagram probably reminds them of what happened with hypertensive medications in the past, too, because there used to be only a few, and now there's many different ones. And I think, one of the struggles as you learn to manage diabetes is how and when and where to combine, to subtract, and eventually just say, stop, and I need to use insulin. Because I think that's one of the clinical inertia questions.
That is a very good point. Yeah, at some point we have to just look at the big picture and say, what are we trying to achieve? So those are the older agents that have been on the market. Again, older being relative within the last 10 or 15 years. So what's really new? And there's a number of ways to look at this. What I have decided would be helpful is to list what are, as far as complete as I could obtain, because this is changing literally monthly, the current non-insulin anti-diabetic medications. And so if we look at this list, we have the group that we had just discussed, which were around for at least the last 10 years, and then we have an entire group which has only been made available since 2005. So it is amazing, because I remember when these agents started coming out in 2005, and we already thought that was a miracle. And then every year since, there's been something that's come out.
So talk to me a little bit about cycloset or bromocriptine, because we've used bromocriptine for a lot of years for prolactinomas and other things in endocrinology. Not so much for diabetes. That's a unique application.
It's a very unique application, and again, it's one of the newer ones that's been approved. I think it's something that there are studies that have been done, and obviously that led to approval. We have a lot to learn about how it works. The idea is that it has some CNS effects, and that may that it has effects on neurotransmitters, perhaps appetite, etc. All of this is still being elucidated.
But it's not a direct effect on the pancreas or
not
on the
as
liver.
far as we know.
It seems more like an appetite suppressant-ish kind of medication.
And it tends to affect prandial, in other words, food-related spikes as well. But I think we have a lot more to learn. It's fascinating because, as you say, this is something that we think of for a totally different endocrine disease that has been found to have implications on glycemic control.
And I get asked a lot, Lillian, by patients when we talk about that hormone amylin. What is amylin? I mean,
Right.
It's starting to show up in a lot of the literature for management of diabetes. What is it?
Right. So amylin is a hormone that's produced by the gastrointestinal tract, and it actually, in many studies, including some of the ones that we've done here at Duke, pretty much tracks the function of insulin in a lot of ways. And so that's also, again, pretty fascinating. And another way of saying, how can we treat diabetes and improve glucose control without actually using insulin?
Right.
Well, amylin is a hormone that is not produced by the pancreas that acts very similar. And so in that sense, this the pramlintide, which is actually the commercialized form of amylin, has been very useful, and it is the one agent on this list that can be used in type 1.
And type 2. So that's
Yes,
why I brought
and
it up,
type
because
2.
this is the
Yes.
one agent that in all of the oral and injectable medications can be used in both type 1 and type 2
Right.
diabetes.
The rest of the list is applicable primarily to type 2. And so in terms of the rest of the list, let's talk a little bit more about the incretin therapies. What is an incretin? It's really a term, again, for a gut-produced hormone, but it refers more specifically to two hormones that are produced that are discussed on a basic science level, GIP and GLP-1. The one that has been pharmacologically utilized the most is GLP-1, although we may hear more about the other. So GLP-1 stands for glucagon-like peptide 1. That's just literally a chemical description. But more importantly, it has a number of effects. Again, GI produced.
Sounds like we don't want to be the pancreas anymore. We want to be the gut. I mean,
it's actually really confusing. I have to agree. Yeah, for whatever reason, and this is why I think it's so exciting, is that what we thought was our organ of choice, the pancreas, is actually turning out to be a part of all of this. And not to mention it, we talked about the CNS effects with bromocriptine, cycloset again. It's really a gut, brain, and pancreas axis, if you look at that.
Right.
And so highlighting that, GLP-1 is actually secreted from the jejunum and the ileum, and basically it still has a number of other effects. It actually stimulates glucose-dependent insulin secretion. So again, this gut-pancreas interrelationship.
But you can only use it in people with type 2 diabetes because you've got to be making insulin.
You've got to be able to secrete insulin. Yes, and again, that's why type 2 is what we're talking about.
Right.
Correct. It also, again, perhaps because of its gut hormone basis, has an impact on gastric emptying. So that's actually been pretty fascinating. And because of the impact on gastric emptying, it to some degree sort of causes a type of gastroparesis, which is why we sometimes use caution if patients already have gastroparesis.
All right.
And in that situation, the goal is to then have a reduction in food intake. In addition, again, based on some of the issues we discussed earlier, it improves insulin sensitivity. And another key point, which I think is fascinating, is that they have an animal data. There still needs to be a lot of translation from animal to human studies. But in animal data, there may be an implication that GLP-1 as a hormone may actually protect beta cell function.
Ooh, that would be important.
Which would be an amazing thing to have a protective medication in concert with something that's as effective in all of these different ways. So again, it's really the sort of gut-brain axis, and we've discussed a lot of these aspects, but the other thing I wanted to point out is that GLP-1, this hormone, in the body is actually rapidly degraded by an enzyme called DPP-4. Why does that matter? It matters because this is why we haven't heard about it for so long. Many people, people have been studying GLP-1 for 20 years or longer, and the question was how to make this useful. And because of the rapid degradation, we weren't sure how this could become a drug at some point. So they've actually, the leaders in this field have actually had two different ways of approaching that problem. One was to actually go ahead and create DPP-4 inhibitors, where they actually block that enzyme, and therefore you have GLP-1 hanging around.
Your own GLP-1.
Yes.
So
what you have made in normal levels that is still there because the inhibition of the enzyme that breaks it down has been put into place. And those medications are known on the market nowadays as sitagliptin, Januvia, and very recently saxagliptin, Onglyza as well. Now, the other way of doing this is to actually just give, as you say, not your own. So literally to mimic the GLP-1 process. And so what they've done is create GLP-1 receptor agonists, and these are injected. And these are known as exenatide, which is Byetta, and recently liraglutide, which is Victoza.
And these are pens?
Yes.
Pens.
Yes.
Okay.
Yes, exactly.
And did they do the injectable as opposed to a pill because the pill is degraded in the gut, or
I don't know. I think it's fascinating. I think the way I look at it is when we're talking about a hormone, we usually need to inject.
Right.
Insulin is injected. GLP-1 is injected. Amylin also. We forgot to mention that. That's an important point. Pramlintide is injected. Yeah. So suddenly we have 2 new injectable medications, 2 new oral medications, and basically these have all been approved since 2005. So a question that comes up from a lot of people is injectable versus oral. Why wouldn't we all just use the oral?
That's right.
You know, I mean,
I get at that all the time.
That's the question. So in other words, why wouldn't we give everybody Januvia and Anglyza? Why do we even talk about Byetta and Victoza? Well, for very good reason. The issue is how they work, we just discussed. One is a situation where it's your own GLP-1 and you block the inhibition and you just have a normal level of GLP-1. And the other is this super physiologic level of a mimic of GLP-1. So the effects end up being somewhat different. The incretin mimetics, that is Victoza and Byetta, are known to have distinct effects on weight loss.
Now, stop right there, because you know that the minute you say that there's a weight loss drug,
right,
which is
I didn't say that.
You didn't say that. Okay. Oh,
I didn't say that.
You didn't say that. Okay.
Yeah. So they have effects on weight loss, but they have other effects, and therefore they are indicated, and that is an FDA-approved indication for type 2 diabetes only.
Okay.
There is no indication for the use of these medications
and
in just obesity.
And we want to be clear about that.
Yes.
Okay.
Yes. And that is actually a key point, because I think a lot of people are hearing this new shot that they can take that may cause weight loss. It's not just going to cause weight loss. It's going to have broad metabolic effects. So that's not, at least currently, approved for weight loss. But if you have someone who has type 2 diabetes and is obese, which is a lot of the cases, then this might be perfect for both purposes. And in that case, you have an individual who can have their glycemic control improved in addition to having weight loss, and that effect on the body weight has been seen in some of the studies to last over 2 to 3 years with repeated taking of the medication, not cessation. You know, it's not a long-term effect without that. But with taking it, they've actually seen some pretty impressive reductions in body weight. Unfortunately, the oral agents don't do that.
Right.
They're considered weight neutral.
Right.
So that's the risk benefit. You know, you've got a pill, easy to take, you know, another pill that we can talk about in diabetes, but we lose to some degree that GLP-1 effect on weight loss.
Okay.
So it kind of depends on what you're trying to gain, but there are a lot of reasons why at least this is worth thinking
about. And just
about.
for our listeners, Lillian, how much hemoglobin A1C lowering effect do these medications usually get? So if you're sitting at 7.5, can you get down to 7?
Yeah, you could probably get about 1% lowering reduction.
Yeah. I haven't seen anything that says it's more than 1%.
Yeah,
so
I think 1% is about the limit. And that's the case with actually the majority of the oral agents as well. And even in and that you raised a point earlier, Diana, at what point do we say we've got to move to insulin? The whole combination, that whole gamut of non-insulin medications, if we put them all together, which you never should, but if you just put them all together, you're still probably only going to get 2% A1C reduction. So someone who is in the teens is going to need insulin.
Right.
That's
and the other reason why they'll need insulin is they've completely destroyed, worn out, and emptied any beta cell function from making insulin.
And that's another concern, is our so-called type 2 patients may in fact be more effectively type 1 in some cases. And so just to finish off the incretin topics, as we talked about the GLP-1 mimetics, again, the superphysiologic mimicking of GLP-1 is basically a medication that has been widely used. This is Byetta and Victoza, which, as we just discussed, can have effects on weight loss, but again is approved for type 2 diabetes. They are not well studied with insulin. That's the question that we get a lot. But the reality is that they have not been well studied with insulin.
Now, Lillian, on your slide, you've got the letters MTC. What does that mean?
Okay. So that's a newer discussion that has come up with the approval of Victoza. In studies leading to Victoza approval, there has been an association with the development of medullary thyroid cancer in animals.
In animals.
In animals.
Okay.
Therefore, they felt it was appropriate to have that as an indication, as a caution. That certainly if there's someone who has a family of thyroid cancer, family history of thyroid cancer, or even multiple endocrine neoplasia, which is often where we see medullary thyroid carcinoma, any of those circumstances, I would not use this medication.
So a question that patients and some of their providers have often asked is if you have a patient with an abnormal thyroid, i.e. nodules that have been biopsied and are felt to be benign, can you use this medication if they happen to have type 2 diabetes?
The technical answer is yes, we need more information, I would say.
Okay.
But the strict contraindication that is in the product labeling is for MENs, multiple endocrine neoplasia, and family histories of thyroid cancer.
Of thyroid cancer.
Yeah, specifically cancer.
Okay.
Yeah, not hyperthyroidism.
Okay.
For example.
All right.
But another key point about these medications is that there has actually been quite a few circumstances of a side effect, and that is pancreatitis. So, as you know, there's nothing that's for free. I'm not terribly surprised if you think about a gut-produced hormone that has effects that are so broad-ranging, including on the pancreas. So we have seen cases of pancreatitis, and that is something to be aware of. Certainly not if you have someone who has a history of pancreatitis, I wouldn't start it at all. But it's not something that I would alarm the patient with, but I would simply educate. I would say, if you're in a circumstance where you start having abdominal pain, nausea and vomiting, come in right away, stop that medication, and let's go ahead and measure labs. So I would not say that it's something that we have to be afraid of. We just have to be aware of it. Moving on to the oral agents, the DPP-4s, as we just talked about, Januvia and Onglyza, the